Lots of fractures, that's something you're gonna see very regularly. The ship is moving like today, so when it's rocky like that, they fall, right? So slip and fall, people slip, fall, break their ankles, break their wrists, when you try to break their fall, So commonly, you see ankle fractures, Weber A, Weber B, Weber C, Colles fractures of the wrists, right? You see your Montegias, your Galeazzi's, your supracondylus of the elbow, Fractures, definitely fractures. You'll be reducing them, splinting them. I've seen dislocations of the elbow that are reduced, dislocations of the phalanges, and again, you just reduce and splint. Mandibular dislocations, and you reduce again. Hip dislocations, yes, twice. What kind of medical conditions do you see on a cruise ship? On this particular ship, we are 2 doctors. In the last 80 days, this is what we've seen. The most common thing we see is cardiac emergencies. So every second day or every day, actually, we get called for a patient that has chest pain. ACS, acute coronary syndrome, or AMI, acute myocardial infarction. Those are very common. Your arrhythmias, right? Atrial fibrillation in an unstable patient. I had to cardiovert that patient actually, and the patient came back all right. SVTs, supraventricular tachycardia, bradyarrhythmias, bradycardias, presumably new left bundle branch blocks with chest pain, 1st degree heart block, 2nd degree heart block, 3rd degree heart block. We get COPD patients with a COPD exacerbation. Core pulmonale, right heart failure, congestive cardiac failures. All those are quite common. Sometimes you get a combination of COPD, heart failure, congestive heart failure, pulmonary edema, bilateral pleural effusions, bradyarrhythmias, or atrial fibrillations, atrial flutters, and all that stuff, And, we get ventricular fibrillations and cardiac arrests, PE, massive PEs. Just last week, I disembarked a patient who had a massive pulmonary embolism, I had to call a helicopter. We evacuated him. He's okay. He sent me an email just 2 days ago to tell me that, he came out all right, that I just discharged him from ICU, and everything was okay, So that's cardiac, that's lungs, pulmonology, or lower respiratory tract infections. We get patients with lobar pneumonia, multilobar pneumonia. Last week again, I had a patient with multilobar pneumonia with severe consolidations of 2 lobes, actually, shortness of breath, dyspneic at rest, saturating very poorly, Yeah, we get your asthma attacks, quite common as well, more in children, actually, Moving from the lower respiratory tract to the upper respiratory tract, that we see every day, your acute tonsillitis, your severe tonsillitis, Quincy's abscess, I've seen that as well. Uveitis. Today there was a kid with croup, Let's talk about the vascular system. So currently I have a patient with a DVT. I've put the patient on enoxaparin subcut 100 milligrams twice a day, because she's 100 kg actually, I've had patients with peripheral vascular occlusions, threatened limbs. Those are medical vascular emergencies, Moving to hematology, I currently have a patient with a pancytopenia, So far, I would call it an idiopathic pancytopenia because I don't have enough resources to actually do further investigations into the exact cause of the pancytopenia. I've had patients with ITPs, I had patients with DICs, I had patients with coagulation factor deficiencies, who just started bleeding on the cruise ships. I had a hemophilic patient. Some few weeks ago, I had a little girl, a 15-year-old, who had a massive posterior epistaxis. You know, she just kept on bleeding, you know, so I had to do a posterior catheterization and stop the bleeding, you know. Talking about metabolic disorders, the number one metabolic disorder that we see is your diabetic patient, type 1, that goes into decay. You know, I've had quite some few decays. The last decay patient, GCS, went down to 3. I had to intubate her. I had to put a central line again. I'm saying again because I just put a central line for the massive PE last cruise, right? So yeah, you know, you get your patient with acute psychosis, hallucinations, and delusional, you know. And then we've got psycho-behavioral disorders related to alcohol intoxication or drug intoxications, you know. Lots of dermatology, yeah. Dermatitis, atopic dermatitis, contact dermatitis, idiopathic dermatitis, fungal infections of all kinds, sometimes a mixed picture of fungal and dermatitis type of infections. Impetigo, quite common as well. Now I've got a patient with vitiligo. And then you've got your abscesses, you know. I had to drain a massive axillary abscess, IND, you know, incision and drainage. I've seen some neck abscesses, some perianal abscesses, some, you know. So yeah, this ship is moving. Sorry about that. Yeah, so this cellulitis, some few days ago, I had a patient with a bilateral distal lower limb cellulitis that was so severe that he had to be on clindamycin antibiotics IV every 6 hours for about 4 days, you know. And then after that, I was able to switch him to oral medication. He came out quite good. I mean, by the time he left the ship at the end of the cruise, I mean, he was really good, and he was so grateful, you know. What else? Your paronychias of the fingers or the toes, your ingrown toenail, you know. I mean, I've done quite a bit of wedge incisions. Ophthalmology, I mean, usually guys from deck or engine, you know. I've had some few corneal abrasions, corneal burns, corneal lacerations, foreign body encrusted on the cornea, stuff like that. And then moving into infections of the eye, usually blepharitis, conjunctivitis, or a mixed picture of blepharoconjunctivitis. I've got 3 patients with that right now. Then you have your chalazions, your hordeolum, you know, all that stuff. The real ophthalmological emergency that I had was a retinal detachment. It was a passenger with retinal detachment, all the signs and symptoms. So, you know, I had to act quite fast. Abdomen. Lots of diseases of the abdomen, appendicitis, perforated appendix, diverticulitis, diverticulosis. All those are conditions I've seen on the cruise ships, right? And then your gallbladder issues, your cholecystitis, cholelithiasis, cholangitis. And then I had a guy with severe liver disease. He was a non-alcoholic, a passenger, and he came in with steatohepatitis, esophageal varices. He wasn't doing good at all, you know. On top of that, he had Korsakoff disease, Korsakoff syndrome, known with Korsakoff syndrome, with some elements of delirium and query dementia by his doctor back home, you know. So that was a challenge, you know. Bowel obstructions, partial bowel obstructions, total bowel obstructions. I had a patient with a volvulus. You've got your hernias, your umbilical hernias, your inguinal hernias, your direct and indirect hernias, incarcerated hernias, strangulated hernias. Moving a bit lower down, or rather to the flanks, your ascending UTI, who's now coming to see you with a pyelonephritis, acute pyelonephritis. Not too long ago, I had a guest, a passenger with a severe acute pyelonephritis, who was having only one kidney because they had to remove one of the kidney years ago because of a renal cell carcinoma. That one kidney had an acute pyelonephritis. I did an ultrasound, and he had quite a large hydronephrosis, Again, I had to put a central line at the end on this patient, a subclavian central line, because, he was deteriorating. Moving lower abdomen, your ovarian cysts. I had one with a ruptured ovarian cyst. Coming to the genitalia, epididymitis, orchitis, epididymo-orchitis. I've never had a patient with a testicular torsion on the ships. Thank God. And then endocrinology. I talked about metabolic emergencies in terms of decay, right? Diabetic ketoacidosis. But maybe in endocrinology, although DM, diabetes mellitus, is part of endocrinology, maybe more specifically, thyrotoxicosis. I had some patients with thyrotoxicosis. Not a thyroid storm, though. That's good. And now, because I'm thinking about endocrinology, moving back to the abdomen pancreatitis, I've had some severe cases of pancreatitis, one that needed a medevac. The severe pancreatitis that I had, it was so severe that he had a diaphragmatic irritation and, ended up with a superimposed pleural effusion and an empyema, Again, this was an ongoing situation, and he came to the medical center very late, Yeah, so that's about, the common stuff we see on cruise ships. I'm sure I'm missing a lot of stuff, but, off the top of my head, that's the kind of stuff we see. Any stuff that you can see on land, you will see on a cruise ship, with the exception of gunshot injuries and stab wound injuries. Right. I've seen few stab wound injuries with a knife. Yeah, so lacerations, lots of lacerations. You're basically going to be suturing. On the one ship, I was suturing every day for a month, every single day. People falling, people slipping, stumbling, falling, hurting themselves. Like, it was unbelievable, And again, it depends on, you can be on a particular ship, and for 1 week, there's no one to suture. And the same ship, a month later, you're suturing every day for 2 weeks, and sometimes twice a day, and even 3 times a day. So it's just random, really, I had a lady that had a massive laceration from about here all the way down to there, It was like a freak accident. She fell and she banged her face against something, But I've put in some nice suture for her, and she was very happy, Minimal scarring, Still talking about trauma, yeah, lots of fractures. That's something you're gonna see very regularly. The ship is moving, like today. I'm a fit man. I'm not overweight. I'm athletic, right? And still, it's hard for me right now, to be still. And when I walk, I was walking just before this. I was stumbling left and right, So just to tell you, right, there is quite a number of guests who are elderly, frail, are walking using canes and walkers and stuff like that. So when it's rocky like that, they fall, right? So slip and fall, slip, fall, stumble, fall. It's quite common, and you get fractures, dislocations, subluxation. That's a run-of-the-mill kind of thing. That's very common. Just the other day, this guy had an anterior dislocation of the right shoulder, of the left shoulder, and yeah, so I did a reduction using the modified Kosher maneuver, and things were okay. Of course, after doing an X-ray to confirm that there were no fractures. Yeah, so, and then, like I said, people fall, people slip, fall, break their ankles, break their wrists, when you try to break their fall, So Commonly, you see ankle fractures, Weber A, Weber B, Weber C. You see Colles fractures of the wrists, right? You see your Montegias, your Galeadzes, your supracondyles of the elbow, yeah, fractures, definitely fractures. You'll be reducing them, splinting them. I've seen dislocations of the elbow that are reduced, dislocations of the phalanges, and again, you just reduce and splint. Mandibular dislocations, and you reduce again. What else? Hip dislocations, yes, twice. Pediatrics, lots of kids, depending on the season. If it's school holidays, then you're gonna get a lot of kids on some of the cruise ships, And yeah, you see croup. Today I had a toddler with croup, right? Acute asthma attack, bronchiolitis, bronchopneumonias, febrile seizures, and then upper respiratory tract infections as well, so that's the situation. So yeah, I've brushed over most of the common stuff, the common medical emergencies that we see on cruise ships. I hope this helps. Cheers.